Hello everyone and welcome to our module on eating disorders. Eating disorders are disorders of abnormal eating patterns that disrupt health or psychosocial function. In general, they're more common in women than men, although they do occur in men, and they usually present in adolescence or young adulthood. And there are three important DSM-5 eating disorders: anorexia nervosa, bulimia nervosa, and binge eating disorder, and we'll talk about all three of these in this video. Let's start by talking about anorexia nervosa. This is a disorder in which diet and exercise lead to a low body weight that is dangerous. The WHO definition of a low body weight is a BMI less than 18.5. You may know that a normal BMI is about 20 to 25. Patients with this disorder have an intense fear of gaining weight, and they have a distorted perception of what is a normal body weight. And the low body weight and the poor nutrition leads to an increased mortality rate among people who have anorexia. It's broken down into two subtypes based on the patient's behavioral patterns. The first is called restricting. These patients have a very low calorie intake and exercise a lot. The second type is binge purging. These patients will sometimes overeat but then purge afterwards. Anorexia often coexists with other psychiatric disorders, and I've listed some of them on this slide. This includes depression and anxiety, OCD and PTSD, and also substance abuse. And often one of these disorders is secondary to the eating disorder, and the other psychiatric disorders improve with weight restoration. Especially depression among patients with anorexia will get better if the weight normalizes. Anorexia and the malnourishment that goes along with it has effects on all the different organ systems in the body, so let's talk about that now. We'll start by talking about the endocrine effects of anorexia. Anorexia has significant effects on reproductive hormones. In patients who have anorexia, there's less GnRH release from the hypothalamus and less release of LH and FSH from the pituitary. In women, this leads to amenorrhea. It's referred to as functional hypothalamic amenorrhea, a very common finding in women who have anorexia. Thyroid function can become abnormal. The most common pattern in patients with anorexia is the sick euthyroid pattern of thyroid function tests. In this pattern, the T3 level is low, but there is a high reverse T3, and the TSH and T4 levels are normal or low. Hyponatremia is very common in patients with anorexia. This is because they take in a very low amount of solutes. This is called the tea and toast diet phenomena, and I talk about how this leads to hyponatremia in the video on sodium disorders in the renal section. Patients with anorexia also have a low creatinine. That's because creatinine comes from your muscle, and these patients have a low muscle mass. And then lastly, if patients are purging, they will have hypokalemia because you lose potassium in gastric contents. Anorexia is terrible for bone mass. Patients with anorexia have low bone density. This is for a couple of reasons. They usually have low estrogen because LH and FSH release from the pituitary gland is suppressed. They also tend to have high cortisol levels. And so this leads to osteopenia, osteoporosis, and an increased risk of fractures. Anorexia can suppress the bone marrow, so patients can have low cell counts. They can have anemia, leukopenia, thrombocytopenia, all from underproduction of blood cells by the bone marrow. Anorexia can also affect the heart. Patients who have anorexia have a low cardiac mass, and the left ventricle can become weakened from this and develop a cardiomyopathy. And in addition to heart failure, this can lead to arrhythmias, which can cause sudden cardiac death. Let's talk about the physical exam in patients with anorexia. Obviously, the body mass index is going to be low, less than 18.5. Mild anorexia is when the body mass index is 17 to 18.5. In the 16s is moderate, in the 15s is severe, and then less than 15 is a very low body mass index. That is severe anorexia nervosa. Other findings on physical exam: the heart rate is often slow and the blood pressure is usually low. There are usually few bowel sounds, and that's because the bowel is undernourished and not moving normally. The skin becomes dry and scaly. This is called xerosis, and there can be hair loss and thinning of the hair. In addition, the hair that does grow is called languo hair. This is soft, fine hair. This is a picture of what it looks like on the screen here. You can see this kind of hair growth in babies, and it will come back in adults if they have anorexia and malnourishment. The mainstay of treating anorexia is nutritional rehabilitation and psychotherapy. So nutritional rehabilitation means structured meals with the patient being observed while they eat to make sure that they meet daily calorie goals. This, coupled with psychotherapy, is how most patients with anorexia are treated. Olanzapine is an antipsychotic drug. One of its side effects is weight gain, and so it is the drug that has been most studied in patients with anorexia who are struggling to gain weight. And then lastly, certain patients with anorexia merit hospitalization if they're in danger of dying from the disorder. These are patients usually with very low body weight or hemodynamic instability, or patients who have volume depletion, or patients who are completely refusing to eat. When patients with anorexia begin to eat and put on weight, you have to feed them gently or else they will develop a life-threatening disorder called the refeeding syndrome. This can be seen in any malnourished patient if they begin eating again too quickly. What happens in the refeeding syndrome is hypophosphatemia develops. Because of malnourishment, these patients begin refeeding themselves with a low phosphate level in their body. When they take in glucose, this increases insulin levels and this increases metabolism. And many elements of our metabolic activity in our body consume phosphate. So this causes a further drop in phosphate as cells begin to take it up because of the high insulin level. When that happens, there isn't enough phosphate around for ATP, and therefore cardiac and respiratory failure occur, and that's why this can be fatal. Most of the deaths from refeeding syndrome are cardiac. These patients develop low contractility and low stroke volume. That leads to heart failure symptoms and also arrhythmias. So the way to avoid this is slow refeeding, and that's why the increase in calories for patients with anorexia is always done gently to make sure they don't eat too much and develop the refeeding syndrome. Our next eating disorder is bulimia nervosa. Patients with this disorder engage in binge eating, where they eat far more calories than they need, and then inappropriate compensation to avoid gaining weight from the food they have eaten. This could be vomiting, which is known as purging. It could also be use of laxatives or diuretics or enemas. Sometimes it's excessive exercise, and sometimes it's fasting after a binge. Other times it's just a severely restricted diet following a binge episode. To meet criteria according to the DSM-5, the eating pattern has to be present at least once a week for 3 months. And in contrast to anorexia, patients with bulimia usually have a normal weight. They consume enough calories to maintain their weight. The problem is that they go through episodes where they binge, followed by abnormal compensation, and that's what they are doing to maintain their weight at that normal level. And just like anorexia, bulimia commonly coexists with other psychiatric disorders, especially anxiety and depression, but also PTSD and substance abuse. When the inappropriate compensation in bulimia is purging, patients can develop the purging complications shown on this slide. First of all, they will have an increased bicarbonate when you measure their serum chemistries. The bicarbonate goes up anytime you have vomiting because acid is lost in gastric contents. In addition, vomiting can contract the total body fluid volume, and that can lead to a contraction alkalosis. There's potassium in gastric contents, so hypokalemia occurs in people who are purging. And then lastly, hypochloremia also occurs when you're purging because you're losing hydrochloric acid from the stomach. This causes the serum chloride to be low and also the urinary chloride to be low. So let's talk about the urinary chloride. You can measure the urinary chloride content, and this is useful when you're working up a metabolic alkalosis of unknown cause. If a patient has a metabolic alkalosis and the urinary chloride is low, that means they are vomiting or in some way losing gastric secretions. You can see this in patients who are having suctioning from their GI tract. You can also see it in patients with bulimia who are vomiting. If the patient has a metabolic alkalosis and the urinary chloride is high, this means they have some other form of alkalosis besides vomiting, because vomiting and loss of gastric secretions always gives you a low urinary chloride. So the classic board scenario is a young woman with an unexplained metabolic alkalosis. The urinary chloride is measured and found to be low. That woman is surreptitiously purging. She hasn't admitted it to her provider, but the evidence is there in the lab testing. Another complication of purging is parotid swelling. Patients who are purging stick their fingers in their mouth, and this stimulates the parotid glands. And if this is done over and over again, it will lead to parotid gland hypertrophy. This is called sialidinosis. And this can be appreciated sometimes on physical exam by examining the side of the face. And then bringing all those gastric contents up into the mouth leads to erosion of dental enamel. And so dental caries and teeth problem are common in patients who are purging. Russell sign is a classic finding in patients who are purging. Russell sign refers to scars on the knuckles from induced vomiting. This is a picture of what it looks like on the screen here. You can see there's damage to the knuckle right here. The treatment for bulimia nervosa is nutritional rehabilitation and psychotherapy, just like for anorexia. SSRIs have also been studied and found to be of some benefit, so they are sometimes used in patients with bulimia. Our last eating disorder is binge eating disorder, and as the name implies, patients with this disorder engage in binge eating. Binge eating is compulsive overeating, often of very large amounts of food that are eaten very quickly. Patients who binge eat feel like they lack control, and they also often feel shame and embarrassment about how much they have eaten and how quickly they have eaten. The difference between this disorder and bulimia is that in binge eating disorder there's no inappropriate compensation, and as a result the patient gains weight and becomes overweight. And to meet the DSM-5 criteria, episodes of binge eating have to occur at least once a week for 3 months. Just like other eating disorders, binge eating disorder often co-occurs with other psychiatric disorders like anxiety and depression. And then, as you can imagine, studies have shown a high risk of type 2 diabetes in patients with this condition related to the obesity and weight gain. The first-line treatment for binge eating disorder is psychotherapy, and it's high yield to know this. Cognitive behavioral therapy, a form of psychotherapy, has been shown to have a very large clinical effect in trials, greater than the medication effect. So for your boards, they're going to want you to know to pick psychotherapy as the first-line treatment for binge eating disorder. SSRIs are sometimes used, but they're less effective than psychotherapy. Besides SSRIs, there are 2 drugs that have been studied in binge eating disorder and have some benefit. The first one is lisdexamfetamine, which is an ADH stimulant. It suppresses the appetite, and that's why it was studied in binge eating disorder, and it was shown to have some benefit. The second medication is topiramate. It's a seizure medication, and one of its side effects is weight loss. So that's the reason it was studied in binge eating disorder. And in clinical trials, both of these drugs have been shown to increase the rate of abstinence from binge episodes, and both have also been shown to lead to reduced weight. And that concludes our module on eating disorders.